So my name is Steve Kitchen. I'm a laboratory scientist. I work in the Sheffield Hemophilia and Thrombosis Centre, Sheffield, UK. For a number of years, I was chairman of the WFH Laboratory Sciences Committee. And during that time, it was a real privilege for me to be involved in a really important piece of work by World Federation of Hemophilia, the update in their comprehensive haemophilia guidelines. This is a document, it's a comprehensive document. It's about 160 pages. It's available for free. Can be downloaded from the WFH website. It's an initiative which was led by Professor Alex Srivastava, Glenn Pierce. And again, I was very pleased to be involved in the section related to diagnosis. This is covered in chapter 3, where we describe some of the important issues related to laboratory diagnosis, but also treatment monitoring in relation to replacement therapy. So in this presentation, I want to discuss the section of the updated WFH Haemophilia Guidelines, which deals with laboratory diagnosis and monitoring. These are my disclosures. And most importantly, these are the co-authors involved in constructing this particular chapter. For such a comprehensive undertaking, it's always a team effort. There's a huge number of colleagues involved. These are the colleagues who contributed to the writing on the laboratory diagnosis and monitoring chapter. It's important to remind ourselves that different bleeding disorders may have very similar symptoms. So they present in similar ways, and it means that we have to consider a number of options when trying to obtain a full and a correct diagnosis. And of course, it's really important that we get the diagnosis right so that the patient gets the appropriate treatment. One of the critical aspects, maybe the most important aspect of getting a correct diagnosis in this area, we need knowledge and expertise in our coagulation laboratory staff. It's really important to have this. Those staff need access to appropriate equipment, the correct reagents. It's not always guaranteed. We'll discuss a little bit later the importance of adequate quality assurance. It's important to remind ourselves also that the diagnosis of haemophilia really relies also on a good understanding of the clinical features. It's important to have good dialogue between clinical colleagues looking after patients and laboratory scientists performing the tests. We really need both of those components together in order to be confident of an appropriate diagnosis. We're likely to be using screening tests, prothrombin time, activated partial thromboplastin time, maybe screening tests of platelet function. We're likely to be using these in the initial investigation. They're not sufficient alone. We need specific tests to make an appropriate diagnosis. And for that, we need specific factor assays and once again, appropriate reagents. So one of the recommendations we've made in this chapter is that it's important to have the correct staff with appropriate knowledge and experience in coagulation, with equipment and reagents available, methods which have been specifically validated for their specific purpose. And we really wanted to include this because we hope that laboratories can use these recommendations to help secure appropriate funding in order to deliver this diagnosis, really critical. And we've got a laboratory manual containing full details of a whole series of laboratory investigations, specific methods, and this has been constructed on behalf of the World Federation of Hemophilia, and it's available once again for free download, and you can see the location of that on the right-hand side here. It can be downloaded in full or individual sections. It's available at present in 5 different languages, and they're the ones that WFH would normally use for their documents. The quality of our coagulation laboratory results, the quality of those results absolutely depends on a good quality blood sample. And we've got some recommendations described here on what type of blood sample to use. We need the appropriate anticoagulant, citrate tubes with a specific range of concentrations, as you can see in this slide. And these have to be appropriately handled during their processing. In particular, it's important to maintain such samples at ambient temperatures between 18 and 25 degrees. The samples should not be refrigerated. If we do that, we can see a loss of factor VIII, we can see a loss of von Willebrand factor. So we must avoid that and keep them at ambient temperature. There are specific centrifugation conditions described here, and it's crucial that we complete any investigations within a restricted interval between sample collection and testing, within 8 hours of sample collection for most of our tests of hemostasis, within 4 hours for factor VIII, and also for platelet function. If we are not able to complete those tests within that time, then it's acceptable to store samples deep frozen. But if we do this, we have to use suitable conditions, and this means minus 35 degrees or lower. We should avoid use of minus 20 freezers. They're cheaper, but there can be problems. I mentioned already that we would begin some of our investigations with screening tests like prothrombin time, APTT, but there are many different versions of these methods. 20, 30 different reagents can be used from different manufacturers, and they're not all identical. They don't have the same characteristics. We need to be aware of the limitations and the sensitivities of whichever reagents we have access to. And we can get information about this from results of things like proficiency testing, quality assurance programs, for example, the WFH program. We'll talk about that a little bit later. We should also keep in mind that screening tests have some limitations. And what WFH recommend here on this slide is a reminder that we cannot use a normal APTT to rule out the presence of mild hemophilia A or hemophilia B. In some cases of mild hemophilia A, hemophilia B, we will see an APTT within the reference range. It's particularly likely for factor IX, hemophilia B, when the factor IX is 25, 30, 40 IU per deciliter. Sometimes that will be associated with a normal APTT. So we have to keep that in mind in our interpretation. It's also true that there are particular molecular defects leading to mild hemophilia A, which lead to different results by different types of specific assay. And this is the reason why WFH recommends that in those initial investigation of patients where there is a clinical suspicion of hemophilia A, the recommendation is to use not one or other of these two types of assay, but both a one-stage and a chromogenic factor VIII. And that's because there are cases who have totally normal one-stage factor VIII, despite the presence of genetically confirmed hemophilia, bleeding symptoms consistent with mild hemophilia, but a normal result by one-stage assay. Those patients have a reduced activity when the factor VIII is determined by chromogenic assay. So they're only detected by chromogenic assay. The reverse can occur, although it's much less common. About 5 or 10% of mild hemophilia A patients in the UK will have a normal one-stage factor VIII assay and are only detected by the chromogenic. It's a much smaller proportion where that's true for the reverse, let's say. So we need to do both. Now, if we turn our attention to monitoring replacement therapy, I think it's important to be able to successfully monitor replacement therapy, factor VIII, factor IX, hemophilia A, hemophilia B. This allows us, I think, to make best use in some settings of what can be an important and restricted resource. And so we have to keep in mind that there are a number of published studies which have described important differences between results obtained in different types of factor VIII assay in relation to hemophilia A replacement, or in factor IX assay in relation to hemophilia B replacement. So samples containing clotting factor concentrates, CFCs, particularly where these have been modified to extend the half-life, so EHL, extended half-life, factor VIII, extended half-life, factor IX, these are particularly associated with important differences between results obtained with different assays. Can we tolerate a difference in results between different assays? A small difference is acceptable, and there's no clear consensus on how big a difference might be important enough to change a patient management. But there is a consensus perhaps in some studies, let's say, that perhaps 25 to 30% difference is enough to start to potentially influence patient management. So that's an important difference. Where two assays give a different number, how do we know which is the truth? Which one would we use? Well, I think in this case, the important information comes from the concentrate itself, the labeled potency, because the clinical trials establishing which is the correct dose in units, those clinical trials use the units from the label of the vial, from the label potency. So in the lab, we want an assay that gives the same number that agrees with the potency. And this becomes the most important result. It correlates with the clinical efficacy of the material. And because there are differences between results obtained with different assays, it's important that we carefully select an assay in the laboratory. And this is a recommendation, a general recommendation here in relation to post-infusion monitoring factor VIII or factor IX. We in the lab should use an assay which has been specifically validated for use with that specific concentrate. So we need drug-specific, concentrate-specific information. Yes, this assay can be used. It's been validated for this purpose. I think this is really quite important for the reasons that we'll discuss in a number of the following slides. So beginning with monitoring factor VIII replacement therapy. So we have a number of recommendations in the guideline dealing with a number of the different individual products, particularly those which have been modified in order to extend the half-life. This can lead to possible differences between results in different assays. So this slide makes a recommendation in relation to monitoring of Eloctri loctate, different proprietary names in different regions. Actually, thus far, at the time of this discussion, we don't, to my knowledge, have any evidence of assays which are unsuitable. It means that we can use our routine one-stage or chromogenic assay to monitor this product. And of course, that's really quite convenient. That's not the case for all of the products available to us. So looking at each of the other modified factor VIII concentrates in turn, this slide relates to N8GP, proprietary name Esperoct. You can also see on here the WHO international non-proprietary name. These are a little bit cumbersome in my opinion, and I think it's the reason why most of us, many of us, talk and use the proprietary names. So I think it's convenient just to remind ourselves of these. So this slide relates to Esperoct N8GP, and the published data thus far indicates that we can use different types of chromogenic factor VIII assay, and some versions of APTT-based one-stage assay are suitable, others are not. So chromogenic assays, all fine. One-stage assays, some are suitable and others are not. And in bold on the top part of the slide, you can see some reagents identified by name. These have been studied in publications and shown to be suitable, and so they could be considered for use. But in the remark at the bottom, you can also see other reagents which have been checked, studied, and in which there are significant differences, in this case, significant underestimations of the true factor VIII activity, and therefore these assays should not be used for this particular product. A different type of extended half-life factor VIII, also half-life extension done by pegylation, as in the case of Esperoct, but a different method of pegylation for this product, Jivi, on this slide. And it means that there are different relationships when we look at results obtained by different assays. Once again, chromogenic factor VIII assays, those which have been studied and published, all suitable for use. And once again, in relation to one-stage assays with APTT-based methodology, some reagents are acceptable, others are not. And in bold in the upper part are those which have been confirmed as suitable. And in the remark, now are some reagents which significantly overestimate the real activity. You can see a couple mentioned, and others which significantly underestimate. And of course, we don't want either situation. I think it's a particular problem if we overestimate, because we would risk the possibility of false reassurance. We think perhaps there is more drug present than there really is, and that might give false reassurance in relation to possible additional treatment and so on. So I think we really want to avoid overestimation at all costs. A third type of modified factor VIII, where the extension to half-life is a consequence of pegylation, is shown here, adenovate adenovi different trade names, proprietary names in different regions. And I think there are a number of publications, and to date, to the best of my knowledge, none of the data would indicate that versions of one-stage assay are unsuitable. So it seems likely that one-stage assays are all, those which have been studied, are all suitable for monitoring this particular product. But there is to some extent a conflict in the findings of different publications in relation to chromogenic assays for this product. A field study looking at chromogenic assays in a number of different countries concluded that chromogenic assays could be successfully used, did recover appropriate levels. But in contrast, a smaller study, I think it was a Swiss 506 lab study, came to a different conclusion that identified some potential issues with chromogenic assay. And this little bit of conflict, let's say, is the reason why in this current document, WFH recommend that more laboratory data would be helpful. Another modified factor VIII, not necessarily with an extension to half-life, but which has been modified, constructed in the form of a single chain recombinant factor VIII molecule. Again, there are some data confirming that there can be important differences between results obtained with different assays. Once again, the recommendation that different chromogenic factor VIII assays can be used. So we've got a consistent finding across these extended and modified proteins for factor VIII, chromogenic factor VIII, suitable for all of these different products. Some versions of one stage not suitable for some of these products. So we can always use the chromogenic, so it may be convenient to take that route. The summary of product characteristics related to this particular material, Afstyla, indicates that one-stage assays will underestimate the real factor VIII activity and raises the possibility that the assay can be performed by a one-stage technique and then the result can be multiplied by a factor of 2. My personal view is that this is a little bit difficult because it's not difficult to make the maths, but there's the potential for transcription errors when the results are being assessed. So I think it's not something that is without the potential to cause problems, let's say. So if we turn our attention now to monitoring factor IX replacement therapy. So again, there are a number of drug-specific, product-specific recommendations contained in the guideline. This one relates to recombinant factor IX FC, proprietary name Alprolix. So just as for factor VIII, there are chromogenic and one-stage assays. Also the case for factor IX, we have available at least 3 chromogenic factor IX assays, published data on at least 2 of those, and a number of different versions of APTT-based one-stage assay. And once again, we have published evidence that some assays are not suitable for some products. So in relation to Alprolix here, chromogenic factor IX assay studied to date are suitable, can be used. Some one-stage assays and some of the APTT reagents in one-stage assays which can be used are shown in bold in the upper part, but there are some in which the published evidence confirms that there is a significant underestimation of the real true factor IX level, and you can see a couple of reagents in the remark which should not be used for this reason. Turning to another version of a modified factor IX, proprietary name Idelvion, recombinant factor IX FP. And again, we've got some published evidence. In this case, there are some one-stage assays which have been validated, which can be used. And again, some of those are shown in bold in the recommendation. What we have seen in the literature related to this product is that at least 2 chromogenic factor IX assays show a significant overestimation. And we also see overestimation with at least one version of one-stage assay. You can see the reagent in the remark. So once again, some methods suitable, others are not. We need to pay careful attention to this. A third type of modified factor IX with an extension to half-life, N9GP, proprietary name Refixia Rebi9 in different regions. And this is a factor IX which is a half-life extension by pegylation. This can be successfully monitored by chromogenic assay, as mentioned in this recommendation. And there are a couple just a couple of one-stage APTT-based assays which have been shown to be suitable, and the reagents are named in the recommendation. The majority, most one-stage assays would not be suitable for monitoring this product. There are some with overestimation, others with underestimation. So we have to, again, carefully select the assay. Moving now to non-replacement therapy. A very important development has been the arrival of Emicizumab, an engineered, carefully constructed bispecific antibody. It's an antibody that binds human 9A or 9 and in addition human 1010A. It's very specific for human proteins. Of course, in a patient, the 9A and 10 are human, but in our laboratory reagents, we do sometimes utilize bovine proteins, and that's relevant to this drug. We'll come back to that point. So the drug itself recognizes human proteins. It's a mimetic for factor VIII and performs some of the functions and delivers some of the hemostasis that factor VIIIa would deliver. Because it mimics factor VIII in many lab tests, there are a number of changes to our laboratory assay results. APTT, irrespective of which reagent we use, irrespective of which patient, once they're on Emicizumab, it's rapidly reduced. The APTT is within or often below the lower limit of normal of the reference range. And this is the case for all the reagents that have been studied. So we see a normal APTT. As I mentioned, it is very specific for human 9A10, not bovine proteins. So when we think about chromogenic factor VIII assays in the lab, and I'll mention some situations in a moment where we need to do that, then we have to pay attention to the source of 9A and particularly the source of factor 10. If the factor 10 in our chromogenic factor VIII kit is human, if it is, Emicizumab will bind to it and will show up, it will interfere, it will influence the results. If, on the other hand, we use a chromogenic factor VIII kit in which the factor 10 is bovine, this is not recognized by Emicizumab, there's no interference. We have the option to measure the concentration of Emicizumab in patients who are under therapy. It may not be regularly needed, but there are likely to be situations where it will be necessary to do so. And if we need to do this, then we can do this using a modified version of our one-stage factor VIII assay. It requires some additional test sample dilution, and we need to make the calibration using drug-specific Emicizumab calibrators, and this is mentioned in the diagnosis chapter. So we've got some recommendations in relation to Emicizumab. If we do need to confirm for any reason, perhaps we might be worried about compliance, if we do want to confirm that Emicizumab is present at the expected concentration, then the WFH recommendation in this chapter is to use this modified one-stage assay with specific Emicizumab calibrators. Those calibrators have not been approved for use in all regions, so we hope that might come in future, but they are approved for use in a number of regions. There are situations in which a patient who's under Emicizumab therapy will, in addition, receive factor VIII replacement. The Emicizumab has a half-life 30, 31, 32 days, so it sticks around for a long time. But if we've got a patient who has a traumatic bleed, perhaps a road traffic accident, or if a patient requires surgery, there's a requirement to give factor VIII in addition to the Emicizumab, which is already in the patient. And of course, if we do that, it may be convenient to check that factor VIII treatment is worked, it's present at the expected levels. If we need to do that, then we can do so with a chromogenic factor VIII assay, provided the factor 10 in the reagents is bovine. Remember that Emicizumab won't interfere in that. Only the factor VIII will be detected, and we can measure accurately factor VIII despite the presence of Emicizumab if we select chromogenic assay, bovine factor 10. Of course, some of the first patients, many of the first patients who will receive treatment with Emicizumab were factor VIII inhibitor patients, and we have requirements in a number of settings. We have recommendations elsewhere in the WFH guidelines that we're now discussing, we have recommendations to make regular checks on the level of factor VIII inhibitors in inhibitor patients. So if that's a patient who's on Emicizumab, we need to pay attention to our laboratory method. And we can do that if we need to measure the residual factor VIII as part of a factor VIII inhibitor assay. Talk more about that in a moment. If we want to do that, then we make our factor VIII assay, once again, chromogenic and with bovine factor 10, so we don't suffer interference from Emicizumab. So we can do this. The incidence of neutralizing anti-Emicizumab antibodies in patients who are treated is really very low. I don't think we know for sure what that level of incidence will be yet, but it's extremely low. That's already clear, but it's not zero. And therefore, if we've got a patient whose clinical pattern during Emicizumab therapy has changed, we may wish to look for the possibility of antibodies having developed against Emicizumab. And if that's the case, then we've got a recommendation here that we can look at the Emicizumab using this modified one-stage assay as already described. So turning attention now to factor VIII inhibitor testing. We know that there are a number of different types of pathological functional inhibitors of hemostasis. In many countries, the most frequently encountered pathological functional inhibitors of hemostasis are lupus anticoagulants. We know that the majority of factor VIII inhibitors will develop secondary to replacement therapy with factor VIII in patients with hemophilia A, and these typically show a characteristic pattern. We can gain some information by some initial investigations based on APTT. Of course, it's a fast and simple, cheap test to do. And it may be informative in some cases to make a mixture of the patient sample with pooled normal plasma, PNP, normal plasma. If that mixture has an APTT somewhere between, intermediate between the APTT of the patient and of the normal, then this can be an indication that perhaps is a factor VIII inhibitor developed. At best, it's an indication. We need a quantification of the inhibitor titer. And we'll talk about that in the next few slides. If there's a suspicion of lupus anticoagulant, perhaps from the patient's history, and there are, of course, also therapeutic anticoagulants which can be used. Heparin is one example. Direct oral anticoagulants are some of the others. So sometimes they can interfere. It depends on the reagents. And so it can be useful if we're running an VIII inhibitor assay. Once again, it's a setting where it may be useful to use a chromogenic assay in place of the one stage because it suffers usually from less interference. So that's something also to keep in mind. So I've already indicated there are a number of settings in which it's important to measure the concentration to quantify the anti-factor VIII inhibitor. And for this purpose, the WFH recommends using the Nijmegen Bethesda assay. The detail of that technique is described in the laboratory manual, again, as I mentioned earlier, available for free download from the WFH website. We should remind ourselves, however, that the Bethesda assay detects neutralizing antibodies. The majority of anti-factor VIII antibodies are indeed neutralizing, those that develop in hemophilia A patients secondary to replacement. Majority are neutralizing. However, they're not all. A small proportion of clinically relevant anti-factor VIII antibodies don't neutralize the activity in the Bethesda assay. They're clinically relevant because they shorten the half-life. It might be 2 or 3 hours or shorter still, but these might not be detected then by the Bethesda assay. So that's just something to keep in mind as a limitation. So this is the Nijmegen Bethesda inhibitor assay. We need a source of buffered normal plasma. Of course, this contains factor VIII. We mix that with two things. We mix it with factor VIII deficient plasma, and this should contain von Willebrand factor. There's some evidence that can affect the results. We mix it with factor VIII deficient plasma, and this is our control mix. In addition, we mix the same buffered normal plasma with patient sample. And so we've got these two mixtures. And if the patient sample contains a measurable level of factor VIII, then we may need to remove that, depends on the level, before we construct this mixture. I'll talk about that in the next slide. We've made these two mixtures, normal and factor VIII deficient, normal and patient. We incubate them for 2 hours, and then we check, have we lost factor VIII? From the patient mix, have we lost more here than what might have been lost from the control? If extra factor VIII is lost, what is the reason? It's because something's destroyed it, an inhibitor. So this is the principle of the test. And I mentioned that we must ensure that the patient sample in this mixture does not contain significant amount of factor VIII. If it's a very low level, 1, 2, 3 IU per deciliter, that just does not have an important impact on the results. But if it's more than 5, it can begin to affect the results which are obtained. And for this reason, the WFH recommends, prior to testing, prior to constructing those mixtures I mentioned, first, the sample is heated, specific conditions described on this slide, and these must be carefully timed and controlled. And then we use that heated material to construct those mixtures that I already mentioned. For all our laboratory tests in hemostasis, it's really important that we have the evidence that our method is under control, that it's delivering reproducible results, precise results, that it's delivering accurate results. So we need a number of components of a good quality management, quality assurance program to help us ensure that we have the evidence. One of the components is internal quality control, and this is where we would test an internal QC quality control material alongside patients. And we use this to confirm that a particular method or technique, procedure, to confirm that this is being performed consistently over a period of time, that we're getting the same answer today as we got yesterday from the same method. But of course, it is possible to be consistently obtaining the wrong answer, a biased answer, an inaccurate answer. So we need a second component. We need external quality assessment, sometimes called proficiency testing. We need this to help identify the degree of agreement between our local result in my lab, for example, and those obtained on the same sample in other centres. This is our confirmation of accuracy. We're getting the correct answer, the same as other centres. So it's really important for a lab to participate successfully in a suitable external quality assessment program. And of course, the lab has to have access to appropriate reagents, techniques in order to deliver the good results in such a program. And for this reason, there are some recommendations in the chapter we're now discussing from the World Federation of Hemophilia. We recommend that coagulation labs implement a proper quality assurance program, really for all the systems that they're using, all the methods that are in use. And as part of that program, there's a strong recommendation that clinical laboratories should routinely participate in an external quality assessment program. Excuse me. And I'm pleased to remind ourselves that the World Federation of Hemophilia operates such a program, the International External Quality Assessment Scheme, IEQAS, and there are a number of participants in this program who will pay a fee to participate, and there are a restricted number of places available to participate where that participation is effectively sponsored by the World Federation of Hemophilia. So there are suitable programs available. So in conclusion, we have a lot to discuss in relation to diagnosis. I hope that you will get a chance to read in some detail the full recommendations that we've constructed in the guideline. And I hope it's clear from there that one of the things that's really important is to have a good, close collaboration, discussion, interchange of ideas, close collaboration between the lab scientists performing the testing and the clinical colleagues delivering the service. It's important that that dialogue occurs so that the service can be properly tailored to meet clinical needs. In order to do this, the lab needs access to the right reagents in sufficient quantities. It's not always guaranteed. Many of us have difficulties in relation to funding, and it's really important that laboratories have sufficient appropriate reagents and equipment in order to make the correct diagnosis. We think resources are an important component of being able to deliver a successful lab service in our area. And crucial to that, not just the equipment, not just the reagents, the quality of the results in our area, very, very much dependent on the laboratory staff, their knowledge, their expertise, important for this to be present. And those are the people who then have the expertise to select the right methods, implement them, validate them, and have the quality assurance to ensure that they're operating consistently, accurately, precisely, safely. Thank you for your attention. I want to also thank the Haemophilia Alliance for supporting developing this presentation.